Welcome everybody to what we're calling the Healthcare Hour of Tenth Presbyterian's 86th Annual Global Missions Conference. Wow. Very exciting. And our first speaker of the hour is Dr. John Kempen, who is an ophthalmologist and probably one of the world experts on uveitis, right?
Sure do.
Yeah, well, okay. Now affiliated with Massachusetts Eye and Ear, but he actually spends 11 months out of the year in Ethiopia seeing patients at my young son Korean Mission Hospital in Addis Ababa. And so they're basically the ophthalmology department, he and his associates there. So, and then he does also inflammatory disease of the eye research while he's there as well.
Wow. Yeah.
And among other things. There you go. And then, John, as you bring me back up, if there's anything else you want to say about your intro, feel free. And Neil Thompson is on his way. Let's put him second, because he already told us he was going to be late. So we're good.
Well, I'd say a little bit about my background as
Sure,
well.
take it away.
So I was thinking it might just be interesting. So I guess I was imagining there would be more students, so many who actually know me already. But anyway, I was going to just talk about our journey in sort of an abbreviated form. So I became a Christian basically by reading the Bible. I went to a church that was sort of very theologically liberal and not very I don't remember anything they said in the teaching, but part of the liturgy was to read the Bible, and so I thought as a child I thought of myself as a Christian. I thought the Bible was the Word of God, and I liked reading, so I read all the time, and so that was how I became a Christian and understood things fairly accurately, although it was when I was sort of in college that I began to be involved in fellowship. And from a fairly early stage, I sort of could see in the Bible that there was a calling to missions, and so I had absolutely no idea how I might pursue missions at that point, but over time, I guess that became more clear. So the Bible, clearly teaches that we should, share the gospel, and that the gospel is saving, and it's a command to do that, and I think everyone can be involved in it in one way or the other. That's, I think, what this week is sort of all about, and a lot of what the church is about all the time. So just in terms of my background, I became very interested in ophthalmology for various reasons. One was that it was very suitable for missions because you can often make an intervention that will last for the patient's life, or at least for many years, with even just a single encounter, and there's kind of a lot of preventable things that can be addressed, and partly just because it was really elegant and beautiful. So I had kind of a difficult time doing research, mostly because the supervisor didn't really know how to guide me when I was a medical student, and sort of had a bad time, but I still really loved ophthalmology, and I've loved it ever since. So I did my training, I thought I might become a missionary, so I did like a rotating internship so that I could deliver babies if I needed to, and then did residency at the University of Washington, and then they had a special program at Johns Hopkins in global ophthalmology and sort of overlapping to epidemiology and so on, and so I sort of had that in mind. It's interesting, they have this Christus Consolator statue under the dome of the original hospital, Johns Hopkins Hospital, although it's been secularized now. It was actually, Johns Hopkins was actually, I think, a Quaker who was a bachelor, I think, or at least didn't have any children, and so he put all of his money into building the university of the hospital. So when I went to this program, I was not really clear what I would do afterwards, and so I thought maybe I should be a missionary, but I was getting very involved in campus ministry, and had been involved in campus ministry really for quite a few years before that, and it was sort of going very well, and I was really loving epidemiology research, and so I decided, well, I'll do this sort of career development program that the National Institutes of Health had, which you had to apply for, but this was kind of like the world's best place to do such a training program, and then I could keep doing campus ministry. And so that was sort of how we began, and sort of for 17 years then, 7 years at Hopkins and 10 years at Penn, during which time I was, I'm still actually a member of Tenth Presbyterian, but I'm not regularly attending. So I was pursuing a fairly typical academic medicine model, so doing a lot of research, trying to get research grants, and like I had sort of prayed that God would, or I had not sort of, I had prayed that God would sort of help me to be able to meet expectations and do things in academic medicine, because it was kind of an overwhelming prospect, and by God's grace that really worked. He really gave that blessing to me, or has given that blessing to me. And so I was sort of, we decided when we came to Penn that we were sort of like rethinking what we would do. Like we came to Philadelphia largely because my wife's family was living in this area. They'd been missionaries for their whole lives, pretty much under WEC International, and WEC's headquarters is on the north side. And so they were living there, and most of Lori's family members were within 2 hours of here. And so that was why we came up from Baltimore, and also there were good opportunities here. And so, but we were just thinking it was kind of becoming harder to do campus ministry as a faculty member, and sort of usually having to see patients or something during the time when the students wanted to meet. And so we came to a conclusion that we would change to do like global ophthalmology development, and sort of coming back to missions idea fairly soon after we came here. About 2008 was when we decided on that, and I was thinking, well, I should finish what I put my hand to with, because I had these big NIH-funded projects, and so I spent several years doing that, and then kind of realized that it's never going to be finished. It's sort of like, at least one of them is probably a lifelong activity, which is great. So we eventually decided to go ahead, and I was sort of going to overseas a lot during that time. We settled on Ethiopia sort of at the end of 2009, and then I was going there for, I guess, 6 years before we finally moved in 2015. And we were, I guess, motivated to change that because, not that there was anything wrong with sort of conventional academic medicine work, but because I was just trying to think, how could I sort of link my skills sort of more efficiently to the gospel, and hopefully to have all of my work be contributing more to the gospel. And you could say, well, through work you are manifesting the gospel or doing work of the gospel, but just to sort of do that more clearly, and especially to do it in a place where it was more needed, where Philadelphia probably has like more ophthalmology care than any place in the United States. And so that was sort of our motivation in that. And so, and also, I sort of, my best skill was doing research, and so I thought I could do academic ophthalmology. Like the academic medicine system or whatever has done a lot to advance healthcare, and so I thought, well, we should try to develop that then. So we decided to go and went in 2015. This is our family at the time, so hard to believe the children were this small, and we were coming to 10th all the time. Christopher was 11, and Peter he was probably still 5 here, but he turned 6 just before we moved, and Natalie was 9. So, and I had been like, I guess, 9 years in Baltimore, 10 years in Philadelphia, so now this is our 10th year in Addis Ababa. I don't think we're going to be leaving this year, but we're sort of reaching our original goals, so we're trying to make a new plan, or sort of like a 5-year plan. So this was when we were being commissioned at 10th, and we moved in August of 2015. And at the academic medicine systems, especially with the sort of fancy places, you were supposed to, in essence, raise support to work there, and basically it's done by seeing patients and by grants. And so I was thinking, well, maybe I could just raise support and still apply for grants, because that was something I was very having good success with. And so I was wanting to do it sort of like under the aegis of a university that would help with that. And so I had talked about that for a long time with my chair, more than 3 years, but I guess the message didn't get through because once we went overseas and my sabbatical time was expired, they were like, you should come back. And so that was what led to, we had kind of invested a lot at that point, and sort of, I guess there's a need to kind of follow through with what you said you were going to do. And we had raised up partners that had moved to Ethiopia as well. And so then I rearranged that, and by God's grace, had an opportunity to do that under Mass Pioneer, which is related to Harvard. And so they were totally open to having like evangelism be part of our program. So they've now sold the hospital to a holding company, and so I'm a little bit worried that it's sort of going a little downhill, but not too bad so far. So what are we doing? So this is sort of the tagline, transforming lives and communities through the gift of sight for the body and soul in Ethiopia. And this part sort of has a timer on it, so sorry about that. So Christ's miracles, the plurality of them was restoring vision, and the image of restoring vision is sort of like a good image of coming to faith in Christ and being saved. Technically you would say that people never had vision before, so it'd be more like giving vision or whatever from a theological perspective, that you were born again, and but even born again sort of sounds like that, but like spiritually born and no longer dead, as Martin Luther would have said. And so, but it's sort of a great image of that, and so that was one of the things that appealed to me about ophthalmology. And so we thought that, by using the skills that I had, which were related to ophthalmology, that this would be a good way to approach mission. And so that's this was sort of what we thought we would do. So kingdom-focused, comprehensive blindness alleviation, and a certain model. I think I have an example of that, or a diagram of that in a minute. And then to do it in partnership with churches to enhance kingdom ministry, and then to professionally train and disciple the ones that are interested of trainees, and to have it be sort of academic in its orientation. So I decided I would just keep doing research. And by God's grace, that's actually worked really well. I'm actually having a lot more publications than before at this point, although there was a considerable latency when we first moved because everything was disrupted. And to serve all, but to sort of have a special focus on serving the poor, sort of with a cross-subsidization model where people would pay currently $5 to be seen, and then that would subsidize the poor patients. So we've had a lot of backers, including Tenth, has been supporting us all along, and I think maybe 4 times has included our ministry in the Easter sacrificial offering, which is geared especially towards services to the poor patients, but quite a few others, including grants from NIH and the U.S. Agency for International Development and some other charities. And Mass Pioneer has contributed some too. So one of the things that I had noticed and been very impressed with was that in India there were several places, this is the second biggest one, had developed a self-sustaining model of eye care where they would do just what I described. They have, this particular one has 4 levels. So there's free, there's sort of half price, there's sort of full price, and there's sort of double price. And people just say which one they want. And so they brag, if Bill Gates came in here and wanted to get free eye care, he can get free eye care. And they sort of ration it though in terms of like it takes you a lot longer to get through the system if you're in the free category, but you end up with all the same doctors in the same rooms and the same service, and so it's a good model. So we don't have kind of the scale to have 4 levels, so we kind of have 2 levels now, paying and free, but because our hospital that does the financial management can't really handle more than that, they say. So, but we were trying to do this model because these have become extremely huge, and in India, this model has been associated with this massive increase in the volume of cataract surgery done. This was partly as a result of a World Bank funding program as well. But it got into 5,000 per million per year range, which is higher than like the UK. And so this model has really been transformative in terms of services and in terms of training. And so a lot of my interest sort of from a formal side was to try to show that this model could work in Africa, where the sort of the world's greatest need is. So our clinical services, then, we aspire to be self-sustaining, and indeed are self-sustaining now for the last 30 years, at least in terms of being able to pay all the things that we're able to pay for in Ethiopia. Ethiopia has certain restrictions that, like, you can't change currency in practice unless you do it on the black market, which isn't allowed for our hospital. And so we have things like, I will get them to buy my plane tickets, and then I get it reimbursed just like for souls, and then we buy the things that we need. And but that's gone very well, praise God. And then we're trying to do various things, including outreaches. And so the outreaches are the things that have really been the most spiritually productive. It's been kind of difficult to have like systematic evangelization in the hospital because it's sort of been softly forbidden by the government, and kind of just difficult if patients aren't there very long. So the hospital does do like rounds, the chaplains will round on patients that are admitted to the hospital, but for outpatients that are there briefly, it's been difficult. But with the camp model, I'll show in a minute, the outreach model, we can just basically preach the gospel, and we do that with partners like churches and like a campus crusade thing. I was introduced by another charity to a program called American Schools and Hospitals Abroad of the U.S. Agency for International Development that is willing to contribute equipment if you sort of successfully compete for it. And by God's grace, we've successfully competed 2 out of 3 times now, so we've gotten about $1 million of new equipment and have really excellent equipment now, like similar to what Mount Sinai or Inwood had. Not as much, but it's been good. And so this is Dr. Demisay, the Ethiopian partner that we launched this with. So he's probably our best surgeon. So I don't actually do any surgery. I stopped doing surgery in 2007, and it's kind of better. Like, I view that my position should be to be a catalyst. And so once the Ethiopians can do things, I shouldn't really be doing it anymore. So he's leading that, and others are doing surgery as well. So this has been sort of the growth in the number of visits that we had over time, and it's probably similar to slightly more this year. We're kind of getting squeezed by space now, but we had, something happened in 2020, which some of you might be able to remember, that interfered with the volume that year, but then we kind of resumed after that and caught up, I think. And the volume of the eye clinic is actually growing faster than the whole hospital, so that's been encouraging for us. And the hospital is growing, it's just the eye clinic that's growing faster. So with the outreaches, we typically do them in partnership with local churches and Great Commission Ministries, which is the Campus Crusade local campaign. And this is operating on weekends, and we'll usually screen about 150 people. And so this is sort of the main thing that Tenth Presbyterian Easter Sacrificial Offering has been supporting. And we also support it from other donors and some from just the proceeds of the clinical work, since we now have a surplus. And so we're growing this now because we were sort of shut down, mostly shut down for a long time because of the COVID. It was like banned to have a big gathering, so we couldn't like bring 150 people together and screen them all. And so someone else made this slide. I don't think we always have free glasses, like this would be a nice thing to add, but we're sort of working into that. We've been mostly focusing on cataract surgery. And then this is a new building that it's a Korean Presbyterian Church that started the parent hospital. And so the founder pastor there just came to launch this new building, which is supposed to be for free care all the time. And so we're sort of working out how to set up within this, and they'll have like a brick and mortar sort of permanent free service thing. So in addition to sort of the center development, training is sort of another big focus of what we're doing, and especially subspecialty fellowship training. So to retain doctors in Africa, people need to have like opportunities to have a good career. And so part of that is to be able to make money and send your children to private school, but part of it is to sort of be the, at the apex of what you could do in your field. And so doing such training is, in my view, really strategic for retaining ophthalmologists so that they don't all move to Maryland and become an ophthalmic technician, which happens not infrequently. And so we've now started a program in uveitis and have one graduate who we awarded the certificate about a month ago, and then another graduate who we haven't awarded the certificate because that's been kind of jointly with Indian programs, and he's staying for a while to do advanced cataract surgery training. And so we have a third trainee that has about 50% completed the program, but has taken leave because of pregnancy now, and so then we're looking to get more. So that actually like doubles the number of specialists in sub-Saharan Africa. Others were only in South Africa before, and so that's anyway, still kind of a drop in the bucket, but we're hoping sort of over 50 years we can make this kind of service available to people in Africa, which has never been available before. I didn't really realize that when we started, but I began to see it happen, because I realized like I'm the only one seeing these patients in all of this area. And so, anyway, so we're trying to focus on that. And also doing that through, there's like two international uveitis associations, and so one of them has kind of come along to be very interested in developing countries' work, and so I'm like the chair of that program of that organization. We're doing like global webinars and local things and conferences in the region. So we're hosting the 12-country conference next year, and I'm hoping to have a week-long program then. We also train medical students at the hospital's medical college, which is a strong medical college, and ophthalmic personnel training. We kind of doing that ad hoc now, but we had an award to do that at first, and then to contribute to residency training at the existing programs. And the idea of training the fellows is that they'll kind of take that over at their programs. So Dr. Mbate there is the first one to be trained. I really finished training her in 2021, but I didn't have any official certificate I could give because Mass Pioneer kind of welched on that. And I guess I didn't sort of cross all the T's and dot the I's adequately. And so, but now since we have our own program at the hospital in Ethiopia, we could give her the certificate, even though she's in essence been a professor in this program already. So anyway, but having this government-endorsed program is quite remarkable because it's the first one of any medical specialty to have advanced subspecialty fellowship training in a non-government institution. That government tends to be pretty suspicious of private institutions, even one that's a charitably oriented one. And so, anyway, so we're working on that. I'm probably talking too long here, so let me go ahead. This is Dr. Mbate and I teaching the other two fellows. So he's the one who's just finished, and then she's the one who's on leave right now. She has 3 small children, so if she was going to India like he did, she would never be able to do that. And so, having the program in the country is really important. So in the research, I've been doing uveitis research sort of all along. I actually was interested mostly in ocular complications of AIDS at the beginning, and I began in 1996. So can any of the doctors remember something that happened with AIDS in 1996? So that was when the antiretroviral treatment that actually works became available, and it was just stunning.
Was that the first one, or was that the cocktail?
That was for our highly active antiretroviral therapy. I think AZT was available in '87 maybe. But so it was like suddenly it was all presbyopia. It reduced the incidence of ocular complications just fabulously. And so uveitis was sort of the other thing that my division at Hopkins did, and so I sort of switched to uveitis research. And I've been doing that sort of all along now for 20 years. Like I mentioned, the 2 programs I was trying to finish, so those were like starting a clinical trial network along with colleagues and doing a large cohort study, which is still going on. I just put in a new grant for that one, which would be the 5th grant. So we'll see how that goes, if they're still open to funding it, but it's still like we're getting to about 50 publications from that project now, so it's doing well. We want to do things that are related to Ethiopia, so by God's grace I was able to get a very big clinical trial grant about trachoma, which is the disease illustrated here, where children especially will get sort of secretions that are infected with this atypical bacteria called Chlamydia trachomatis, and then over time it can lead to scarring on the back of the eyelids that turns the lashes in to scratch the cornea. Usually children don't get that complication, but it's adults that eventually get it. And so the trial is about trying to do the surgery to recover that better. And so we actually just finished the data collection for the trial on October 31st. So anyway, so soon I'll find out the results. As the chair of the study, I'm not allowed to know any of the results until the data collection is completed. So, and this fellow was one of the motivators, who's an Ethiopian ophthalmologist who's sort of a global advocate about trachoma. And we also are doing a project with using like a refraction app that somebody related to Mass Eye developed, which basically measures the far point that people can see, and from that you can largely know the refraction. And so this might be a way to figure out what glasses people in very remote places need, which kind of builds upon this trial, because we're going out to extremely remote places with like 80% completely illiterate and 10% sort of minimally literate. So, so hopefully we can continue to build on that. This is the research team at the beginning for this clinical trial, which we called FLAME. It was fluorometholone as adjunct medical therapy for trachomatous trichitis surgery. So, so anyway, this has been one of my favorite projects, and led to all these people and about 10 more, or 5 or 10 more, getting training in how to do research. And so it's been great. Also, it allowed us to provide surgery for like 3,000 patients. So, so anyway, I've done sort of a range of other programs, and by God's grace, I've been able to publish a lot. So I think 33 papers already this year. So partly that's because of having good partners now that I didn't used to have. So I'm not having to do everything myself, but and still trying to get some new grants. So we'll see if God continues to provide grants. If not, then I'll just kind of refocus and focus more on the development rather than trying to do all, because I am pretty hectic, so it would be not all bad. So, but I've really liked doing the research, and there's been a lot of blessing about that. So I guess I've had 190 publications since Cypress Souls was founded, and 88 crediting the hospital there, including some influential ones. So, so it's been good. So my goals kind of now are similar to from the beginning, but to advance self-sustaining eye care as a pathway for healthcare provision, and doing all of this in Jesus' name, but to try to make health services available that go beyond what the government can afford, which is not that much. They're trying, but it's not. 130 million is a lot of people to pay for when you have basically tax coming from only one city. And so we're hoping to expand the center that we've developed to be like a so-called pyramidal approach, where it's sort of based on like a strong center, and then from that, this really should be kind of upside down. That's sort of the foundation for then reaching out to like less, sort of primary ophthalmology centers, primary optometry centers, and maybe even field workers. And so we're going to probably get into this now with the permanent center for the poor patients at our hospital. So this is sort of a long-term program. And then bringing uveitis care to Africa in particular. So, that's probably a 50-year project that I'm trying to get that going. I estimate that there's about 11 million people in sub-Saharan Africa that will get uveitis, and 6 doctors so far that are specialized in it. And some uveitis can be treated by a general ophthalmologist, a fair amount of it, but often just giving some eye drops isn't enough. And I feel like even when I was in Philadelphia, I felt like when people would come to our so-specialty clinic, it would be really transformative for them, and I feel like it's much more so in Africa, or in Addis Ababa. So from some of our research, we show that these people do better, do not people think this is sort of a dread diagnosis in Africa, but the average patient really gets better over time. In this graph, this is worse, like this is 2020, and this is about 20/120, and different subsets of uveitis, all of them basically getting better, except this subset sort of returning to baseline by 5 years, probably because of some special features of that that create scars. And then bringing fellowship training programs. So I have already started now this uveitis program with Dr. Innovate. I kind of need partners now to do the other ones because I can't personally train the people in those other areas. And then to sort of, I do work on estimating the burden of eye disease with the Global Burden of Disease Study, and then research and development into developing country problems like trachoma and the refractive cap that I mentioned to you. And so these are kind of the things that I'm working on from the sort of technical side. And I would like to, you could pray for us, I would like to see the gospel ministry kind of integrated more into the clinic, but it's been kind of difficult for us to figure out how to do that. And it does work well with the outreaches. So with the outreaches, we're trying to expand that now, and I think have kind of a green light to, expand that a lot. I'm trying to think about whether to expand Sight for Souls more. It's hard to raise money living in Africa, and whether we should stay in Africa. I think we're going to stay in Africa, but we're going, because that's kind of a unique opportunity to be able to do this. And so anyway, but you could pray for us just about that, and because Sight for Souls has not really been growing too much, mostly because I'm not making it grow, I guess, but maybe it doesn't need to, I don't know. So anyway, I was just going to show this, this estimating the burden of eye disease sounds kind of boring, and it creates a boring looking paper, although it's in Lancet Global Health, so it's kind of high impact. But what it means is that 90% of vision loss could be prevented or reversed, and so sort of getting this message out is pretty important, and then doing the training so people can address it is good. So far, then we over time have gotten to serve over 20,000 patient, or at least patient visits per year, and over 500 surgeries per year. So we have reached that threshold after about 5 years. So this, and maybe it would have been 4 without COVID. So we think that this model could be generalized and can be a foundation. I was always kind of jealous of the Indian groups. Not that I don't want them to succeed, but the church should sort of be more involved in bringing these things forward. And so hopefully more brothers and sisters can carry this forward, and maybe Africans can do that as well. And then we've been doing training, had the opportunity for gospel presentations for, and several, I think around 300 patients have responded so far. And it potentially can be leveraged to reach into areas that are more unreached. So Ethiopia is not, we didn't really pick it so much because it was unreached, at least in Addis, that there was a tremendous need. But it does provide some opportunities. There's actually more Muslims in Ethiopia than Saudi Arabia, because it's a much bigger country. And so it should be a good place to work in many ways, although it's kind of a frustrating place. So constantly having insurrections and so on, but not where we live. So, and not where we were doing that trial. And then there's kind of this sense of futility in the situation where people think they can't get good health care in Ethiopia. And So just trying to change that so that, people can get high quality medical care there. It is possible, but it's kind of hard to know how to do unless you are very informed. So for me, it's fairly easy to get good health care there because I know, but for the average person, even people with money, it's not so easy. And there's sort of some sense of futility in the doctors themselves, because it's often very poorly equipped and nobody will fix things, and they don't get paid much if they work in the government sector. And I think like $130 a month, so like about the same as a cleaner. And so it makes it hard for people to stick with it. So although they do make allowances for doing some private practice. So anyway, I think the results of what we've done has been pretty encouraging. And so, hopefully other people will take it up and we can expand. And we should remember, that God calls us to make disciples and to do unto others. This is from the story of the sheep and the goats, but to sort of, do it unto the least of my brothers. So, we're perhaps sort of a little more focused on the service, but we're leveraging it for the ministry as well, since that was kind of my skills with being an ophthalmologist. So anyway, these are still compelling like they were when I was 17 and sort of contemplating, it seems like we're called to do missions, but I don't know how. So maybe I sort of know how better now, that I think it's a lifelong process. Yeah. So, all right, so let me stop there. Hopefully I didn't take too long. If any of you want to
Our
correspond
second
with...
speaker has been 5 minutes away for 10 minutes.
Sorry.
So yeah, do a little Q&A, stretch a little. Oh, you're here!
Hi.
Oh, hi! When did you sneak in?
15 minutes ago.
Yeah, good. Oh, good.
All right, well, does anyone
So
have
we're
any...
good. Well, Q&A though. Q&A.
Yeah.
John, I'm wondering, is there any sort of partnership with your Korean brothers and sisters? Is there room for both of you at the table? Is there any sort of spiritual sharing with them?
Yeah.
How does their, well, in 25 words or less, how does their model differ from yours? And is there a meeting place for
It
it?
actually doesn't differ much. It's mostly differs from ours in not being ophthalmology. So, like, they have the same concept, but they want it to be self-sustaining. They want to do training. In Korea, currently, American missionaries went there like in the 1880s and did mission, medical missions and started training programs, and it all took. And now Korea is like the best in the world, just about. And so
They're the #1 mission sending country per capita in the world.
Yeah, so I was referring to the medical thing, but also in missions, they're the #1 per capita. And so, so their vision in starting this hospital was largely, I think, because of gratefulness to Ethiopia for participating in the Korean War as the only non-colonized country in Africa. And they kind of wanted to do for Ethiopia what the United States had done for Korea. And so, so it's pretty compatible. I think the cultures are pretty different. I feel like it's sort of, I feel kind of like culturally we're closer to the Ethiopians and Koreans almost, but we're getting along pretty well now. We had our challenges over the years. Now there's a new CEO who's a Korean American who was a medical researcher in the United States, and so now it's kind of much easier for them to understand me, as well as like when I talk with them, I actually know what they're saying. When I'm talking with him, I know what he's saying 100% of the time, which has been a challenge. So, yeah, so we're fairly integrated, but we have this agreement that sort of Sight for Souls will be responsible for and have the discretion over the eye department. So one of the difficulties we have now that you can pray for is just, the whole hospital is full, and for various challenges like civil war, hyperinflation, different things, they haven't been able to build new buildings they had planned for a while. And so it's not likely we'll get a lot more space, and we're kind of squished. And so I'm thinking of like having them rent a place. Of course, we're not allowed to rent on our own because of the regulatory thing that they sort of restrict healthcare to Ethiopians unless it's at a full hospital level. But that might be a good option. So I'm going to and the CEO likes that option, so so I have to make sure that the ophthalmology team likes it, because that's kind of just happening now. So if we have to go over at 5, maybe.
Yeah, well,
that's,
I mean, Neil
yeah.
needs to talk, but,
Yeah,
yeah. Well, you don't have, folks, this doesn't have to end at 5, it should end not too far after 5. Between 5 and 6, people visit the booths, and then
Right.
at 6 is dinner.
okay,
So there's some leeway.
yeah. So maybe I should step down and I'll be having
And I-
a booth.
well, are you doing anything with river blindness?
It's not big in Ethiopia. There are a few people that have onchocerciasis, but they don't have blindness basically in that area. So it's mostly in Central and West Africa. That's sort of one of the amazing stories that I was interested in when I got interested in global ophthalmology. Yeah. Trachoma is huge though, yeah.
So, real quick, I wanted to ask too, in terms of your training program, how do you guys try to garner more interest for medical students to go into that type of work as well?
Yeah, so our training program is for fully qualified ophthalmologists. So we so far have just been asking programs to nominate someone. And so the other program in Addis hasn't nominated anyone yet, so we may have to be more aggressive. So now we're sort of just started asking the programs in other parts of the country. So there's 7 residency programs now, so a lot of residents now in ophthalmology. It's growing fast, but it's still less than 2 per 500,000 population. So it's not so many. And many parts of the country which not visit, people gravitate to the capital where they can send their children to a decent school. And so I think some work needs to be done to make it more attractive in the peripheral locations. Yeah. Okay.
Thank you, John. So if we could have our second speaker. Neil Thompson is a local, though he's wandered a bit during his life. Trained here at Jefferson in surgery. Did you do everything at Jefferson? Med school and residency? Med school. And then, where did you do your residency?
Union Memorial Hospital in
Oh, cool. Very good. So, and spent 20-some years doing missionary surgery in Thailand.
Yes, we're going to change continents.
And then came back after that to run his outreach agency, which is, are we allowed to say what it is?
Sure.
Okay, Overseas Missionary Fellowship.
Yeah.
Yeah, the former
China.
China Fellowship, correct. And so
That's where we're going to start.
He was the U.S. director for 10 years. Okay, take it away.
Thank you. Great to be here. I don't have a watch in front of me, so you better give me this one. I'm not going too far. After World War II, the mid-50s, there was a lot of renewed missions interest in the world. China Inland Mission had been in China since Hudson Taylor founded it in 1865. And we all know what happened after World War II. There was a communist takeover of China, and all expats, all missionaries, all business people, all diplomatic people were forced out. China Inland Mission decided they're not going to quit the mission, they're going to redeploy a lot of the missionaries to other countries in East Asia. And they had quite a few hospitals, doctors and nurses, and all of these were sent to Thailand. They had done surveys and found out that in central Thailand, which means north of the capital Bangkok and south of the large city Chiang Mai in the north, there was a vast plain, mostly rice fields in central Thailand, where there were no Christians, no known Christians, there was no medical care. And so the ONF, or the old CIM, decided to complement the evangelistic thrust, discipleship thrust, with a medical thrust. What's the difference between the two? How does one complement the other? For most Thai people, like my friend Dr. Virat, he was one of my first friends when I went to work in the hospital. and we used to go out and run together, we'd eat together, we'd talk, and I'd ask him all kinds of questions. I said, so I hear that most Thai people are Buddhists. What does it mean to be a Buddhist? He said, I don't really know. I just went to the temple. I did what everyone else did. And then I learned that a lot of Thai are nominal Buddhists, like in the United States, we have a lot of nominal Christians. And I said, so how did you become a Christian? And so he grew up a Buddhist in a Chinese Thai home. And when he went to medical school, someone invited him to a Bible study. And this was something that was totally new to him. He had never heard about Jesus, he had never heard about Christianity, he had never heard about the Bible, but he said, oh, this is something different. He went, and eventually he became overwhelmed with this person, Jesus, and he became a Christian. So when I learned, even today, when Thai people become Christians, I asked, so what did your mom and dad think about it? Because I found some would throw their kids out of the house. They'd be like excommunicated. Others were a little bit more gentle. And so his parents were very upset, but Dr. Virat, my new friend, he had been a drinker and a gambler and all kinds of things when he was young. And he said to them, as a Christian, I will be a better son than you've ever had before. And he made good on that promise. And so, back to Central Thailand. Well, we're in Central Thailand, and we're back around the 1950s, and remember, China Inland Mission was sending doctors and nurses there. They started out with clinics. And in 1950, the major traffic route in the Central Thailand was up the river, the Chao Phraya River, which drains the north and then goes down right to Bangkok and enters the Gulf of Thailand. And so there were general clinics at first, and then the general clinics found that there were lots of leprosy patients. Like the survey had told them, lots of leprosy, malaria, and tuberculosis. And after a couple of years, they realized there were so many leprosy patients, there were so many needs that the clinics couldn't take care of. Like, what do you do with appendicitis? You send them how far away to get something done, and they decided we need a hospital to complement the clinic work that was going on and to bear witness to the evangelism that's going on. So a Thai person, like to have introduced my wife at the beginning, Wani, would you wave and stand up? So Wani grew up in a Chinese ancestor worshiping Buddhist home in Bangkok. And for them, listening to the gospel is like listening to another language, because outside of Christianity and the concept of grace, it's not understood. People take care of themselves, their own tribe, their own village, their own family. They're not thinking of grace towards other people. And so Rock told me early on, very difficult for Thai to become Christians, and very difficult and if they do, it's probably going to take a very long time. And so we found out that the verbal witness, the preaching, was not reaching people. But when the clinic started and when the hospital started, and John can probably vouch for this from his eye standpoint, when they saw Christians following Jesus and offering the compassionate care that he showed, they said, wow, we've never seen anything like this before. We've never experienced anything like this before. The touch, the eye-to-eye contact, the care, it's revolutionary. And so that's how a medical ministry complements an evangelistic ministry, and letting people not only hear the gospel, but in a sense, they see the gospel. They see the gospel when it's demonstrated through the love of Jesus Christ. So, hospital was started, modern Christian hospital, very small hospital, middle of central Thailand, rice fields all over. And I'm going to hold there. I grew up in southern New Jersey, in Collingswood, right across the river. So I'm kind of a local kid, like Laura said. And went to Franklin and Marshall College and came to Jefferson. But when I was at F&M, one of my youth leaders in my Methodist church in Collingswood said, would you like to go to a missions conference? I said, why? I'm not interested in missions. But he was talking about the InterVarsity Christian Fellowship Urbana Conference, which was being held at Urbana, Illinois. So this was when I was junior, my junior year at F&M. I went there. John Stott, I think one of the three main Christians in the 20th century, John Stott, Billy Graham, C.S. Lewis, probably are my top three. He was the speaker, and he spoke on 2 Corinthians 3:5, and I still remember, you are ambassadors in my name. And the way he preached, the way he explained, it was like God was speaking to me anew. I already knew that I was a Christian, but there was something powerful about the preaching that I was asking, wow, I had no idea what I wanted to do with my life, but I was thinking, is God calling me? To do what? And then at Urbana, a day or two later, I walked by a room that had a sign outside medical mission. What's that? So I walked in and sat in the back and heard somebody who'd been in Africa talking about his experience. And I thought, wow, I've never heard of that before. So that was the beginning. And then I began to think, oh, my grades aren't very good, but maybe I'll get into med school. And I did. And in my sophomore year, I was thinking, I keep telling people I want to be a missionary, medical missionary. I had no idea what it means. So I talked to a couple of people, and the one who answered me was had been a missionary with CIM, China Indian Mission, Dr. Arthur Glasser. And he said, we got a hospital, Central Thailand, why don't you go there? So he wrote the letters, pulled the strings, and I got to go to Monterey Christian Hospital in the spring of my senior year. So I was out of Philadelphia, left Philadelphia in a snowstorm and arrived in Bangkok, and the airport there was surrounded by rice fields. It's a little different these days. But that experience in Thailand, different people, different culture, different language, different everything, and then to see these foreigners, all of that from around the world, doctors, nurses, OT, PT, it was just an amazing experience. And again, God was speaking to my life, and I said, oh my, is this what I should be doing the rest of my life? And that's what happened. Not the rest of it, but a good chunk going back to Thailand. So I was in Jefferson in the late 60s, and I was here when Dr. Boyce started his pastorate in 1968, I think it was. And the year after that, I went to Thailand as a medical student, and then came back and went through all kinds of training, including surgery at Union Memorial Hospital in Baltimore. And that was good. It was I think it was called a community hospital. It wasn't a university hospital, but it was affiliated with Hopkins. And I had surgical training in many different subspecialties, which you don't usually get. But I think God had specifically prepared me for that place to get training, to let me know what the kidney looked like and how to get there, what to know what this looked like and how to get there. And so you don't want to hear him. Love him best, so we won't stop there. So Monterey and the medical work in central Thailand opened the door for leprosy patients, and when they saw the love of Christ, many of them became Christians, and many of the early churches in central Thailand were leprosy. And then in a little bit of an ironic turn, the other churches were called the well churches. Some of the well churches weren't as well as the leprosy churches, but that's how names get placed. And so we did see churches grow. We did see God working in central Thailand. So that's pretty much my story. What is medical missions like? And that's my challenge to you. We call it healthcare missions now, because we're focusing more on what it means to be a healthy person and not just what it means when you go to see a doctor. So we're running out of time. I've got lots more I could say written down, but if you've got any questions.
5 more minutes.
5 more minutes.
I give you permission.
Where do I go?
5 more minutes. And then Q&A. Unless people are really raring to go look at booths. Which, you know, you can see those after dinner too. So.
Well, I'll go to the end. Monterey Christian Hospital lasted for 50 years. It indigenized, meaning that in the end it was all a total Thai ministry. Thai doctors, Thai nurses, we called that indigenization or nationalization. And it had a big impact on people seeing that the Thai could actually do this. Toward the end, there just weren't enough people to continue the hospital. Closed after 50 years. But the Thai board had been thinking, what do we do when a hospital closes? And they ran, do we make a retirement center? Maybe not. Do we do this? Do we do that? And in the end, they decided to start a modern international Christian school. And so 7 years after the hospital closed, it continued as a clinic, and Dr. Virat still does the clinic at Monterey. But they opened an international Christian school for elementary and beyond into high school. And they started with 4 students in 2014, and now they're up to well over 100. And we were there about 6 or 7 years ago when they had, maybe it was their, I don't know what anniversary it was, but the mayor of this very small town of Monterey, the mayor came and spoke. He's Buddhist, he's Thai, he's coming to this Christian function, and he just said, thank you. Thank you for your Christian community here. Thank you for what you did through medicine for 50 years. And thank you what you continue to do through educating our children in English. And so, you often hear about mission hospitals that open, you don't often hear how they close and what happened. So this is just a little addition to our story about Monterey, this tiny little fishing village in central China. Questions? Laura.
What do you see as trends in healthcare missions these days? Have you studied it all or informed it all? Kind of like if missions hospitals in some places are closing, what are the alternatives, or where do people go? How does it work these days, opportunity wise?
Do you get the Evangelical Missions Quarterly?
No.
I wrote an article a year ago about the past, present, and future of medical missions,
Well,
of healthcare missions.
So,
So, mission hospitals in many places became national hospitals. They were nationalized. They weren't taken over. They were usually given or granted. Some have remained Christian hospitals with the local people, whether they were Thai or Indian or whatever. About the number of hospitals, there were probably up to 800 mission hospitals in India at one time, and now they've closed all but about 200. But of those 200, 4 or 5 of them are the most well-known, most famous university medical centers in Vellore in the south, Ludhiana in the north. In the 1960s, the emphasis after World War II, the emphasis of the WHO was what we call primary health care. And a lot of people came rushing in and saying, primary health care, get rid of the hospitals, we want the people to have access. And then other more moderate voices said, let's complement what the hospitals do with primary health care. The primary health care that's done well knows of a hospital they can trust that's not too far away. Not a big hospital, not a tertiary center, but a primary center. And so Thailand now doesn't have any mission hospitals. Monterey became a school, as I said. The 2 other low enough hospitals became local government hospitals. They were turned over. And this has happened in a lot of places. Don, do you have anything to add to that?
I sort of feel like our proper role as Westerners doing missions is to be sort of like a catalyst to, like, there will be development of medicine and the church in all these places, but trying to help it go faster and to help people to reach high quality and so on. So I feel like there's a lot of teaching, especially as a big emphasis that we ought to properly do, just because we have sort of more depth in terms of medical education here than in most other places, and sort of extending that overseas, I think, is a big need. And certainly the people I've interacted with, they're very keen to get a little bit more, like the ones that are successful, they're just grabbing whatever they can get to become expert at things. And so now it's being formalized more, so it's sort of better. Because sometimes people will just start doing something that they're not really prepared to do, and it's not great how that turns out. But and so also like establishing programs where people can be kind of trained ethically.
Barb?
So what I'm trying to get at with my question is, if there are Christian medical students or young Christian young medical professionals who want to serve overseas, what types of opportunities are there if they're not classic mission hospitals in some areas? And so there are some classic mission hospitals, particularly that haven't been totally nationalized yet, particularly in sub-Saharan Africa, some still in Asia, particularly East Asia and Southeast Asia. And then there's also, as John was alluding to, there's lots of opportunities to teach. And then some other models that I've seen where clinics, like you were alluding to, Neil, clinics for expats and Westerners who are working in the area, and then you go and you work in the clinic, and oh, by the way, the expat clinic is, don't tell anybody it's Christian, even though it's in Saudi Arabia or Northern India or, some places where you can't really be Christian and talk, but they're there serving the expats, and then they witness to neighbors and or do outreaches to the local community as the government allows them to do sometimes in their spare time. But other models that you've seen, Neil?
I think Mercy Medical Center in Phnom Penh, Cambodia is one that was set up, that was started by 3 mission agencies, people who work together, and that's grown. Their focus is very much on church planting, and they want especially church planters from different agencies to refer patients in, and then they can witness to them. I think in the OMF world, there are probably the most opportunities in China, Mongolia, and Cambodia. One example of medical people working in a non-hospital would be, we have a nurse and a respiratory therapist married with a little girl working in a village in Indonesia. And they do a TB clinic, and then they outreach, they're great outreach to other people. Similar thing in Manila with a couple, a Swiss couple, doctor couple are working with TB and whatever else that they have to treat. One thing about going back a little bit to mission hospitals is, one thing that I've realized as I've gone back and studied some of this is, most of the mission hospitals that were started by the pioneers, they did community outreach. They went to villages, they itinerated, they went out and they preached and they provided medical clinics. They were doing public health. And so when there was the primary health care being initiated in the 50s and 60s, they were just concentrating on doing more of it and in more places and trying to get more medical care in the villages with the knowledge of where they could send the sick patients when they really needed help.
I think having it integrated is really important.
Okay.
Yeah.
I think being professors is a big opportunity. For people that are not doctors, there's like community health evangelism is kind of a big thing. So like what you were mentioning about a tuberculosis program, it would be watching the person swallow a pill every day for 6 months.
Yeah.
And so it's or longer. And so it's a good opportunity
You know them
to,
pretty well.
Yeah. Any other questions?
And can I also put a plug in for InterServe, who's also here across the way. They do medical outreach to all the stands, and also to Southeast Asia and Northern India. And there are healthcare opportunities for that.
I think the mission agencies that I know that are doing a lot of medical work would be the Southern Baptists, the IMB, InterServe, and not so much, but still about 5% of our medical. Yeah.
What would you say is probably one of the most meaningful experience that you had so far in missions? And the second question is, how can we pray for you?
I think one of the most meaningful experiences was when I operated on a girl early in my time at Monterey who had ruptured appendicitis. And that was really an emergency. And so did the surgery and took some time. She was in the hospital for a couple of weeks. She got better. And then to see her mother want to become a Christian. It was a Christian environment. She heard the gospel every day in the outpatient. She met with people. She saw that people were different, and they saw how her daughter was treated by the nursing staff. And it was very moving. I mean, for 50 years, not that many people became Christians, but there were some, and they helped to start new churches. So that was, and I think John's probably had experiences like that as well. For most medical missionaries, they're still probably most excited, not after the greatest operation they did, although that is good, but it's when people come to know the Lord. Pray for me, my goodness, I'm getting old. What's next? I've retired 2 or 3 times, so I'm not sure. Oh, I could say one thing.
Can you explain Buddhism and the problems of medical care where they clash with each other?
I don't think that they really clashed. Most Buddhists are not really, they're not really aggressive. They just say they're Christians, it doesn't matter, we're going there to get taken care of, and many of them don't even listen, don't even care. I wouldn't say there were any clashes. Yeah, but
they in terms of their worship, they think they're right. That's the one problem.
they think they're right, but they're really pretty passive about it. This is Thailand. This is not Burma. It's not other more aggressive Buddhist societies. They're not forthright about it, but they're not easy to change. Yes.
Hi, my name is Nana. I'm a medical student with the Philadelphia College of Osteopathic Medicine. I'm a little bit interested in hearing about like any collaborations or conversations you or your organization has engaged with like international organizations like the CDC or WHO or the United Nations, and maybe specifically on like a clinical or public health capacity.
I would say most of the medical work that LMF did was very small. It was, I mean, we knew about WHO, CDC. They wouldn't be, well, how would I say, partnering with entities that are that small as what we did. ONF decided, China Inland Mission decided very early on to go to the rural areas, to go where other people hadn't gone. We didn't go to big cities, and so we weren't usually cooperating with the giants of medical care. I wanted to say one thing about a course that I've been involved with for the last 5 years. There's a course called Christian Global Health in Perspective. If you've heard of the Perspective movement, this is the medical adaptation of the Perspective movement. So tracing medical missions through their biblical foundations, 3 lessons, through their history, 3 lessons, and then the cultural aspects of medical missions, and then current concerns and strategies and leadership. And so this has been going on for about 5 years. Academics from California, Connecticut, Wisconsin, from different places in the United States, they got together maybe 6 or 7 years ago, and they've made this happen. And the cohort that we're working with now, it's all on Zoom, or maybe it's Moodle now. We have 20 students. Many of them are doctors, some are students, nurses, from 15 different countries. US, UK, Nepal, Cambodia, Vietnam, not many from South America, a couple from African countries. And so, and it's being talked about mainly through international Christian medical dental associations. Some are taking it because they're missionaries and they want a broader knowledge of medical missions. Some are taking it because they want to become medical missionaries and they want to learn some of the foundation material, which I would have loved to have had back in the 70s when I was looking for, but God wanted to do it. So that's a plug for, if you're interested, Christian Global Health, if you Google that much, it'll go right to their website and you can see what it's all about. Thank you.
Cool.
Thank you.
Thank